Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Please note that the information provided in this podcast should not be considered medical advice. We do encourage all listeners to consult their healthcare professionals for medical concerns. Thank you for listening, and we hope you find our discussion today enlightening. Hi, and welcome to SpondyCast. Today, we are going to talk about spotting the signs early, how CT scans could help detect spondyloarthritis in people with IBD. Our guest is Dr. Adam Mayer. He's assistant professor of adult and pediatric rheumatology at Hackensack University Medical Center and the Center for Discovery and Innovation. He is also SAA's 2025 Jane Bruckel Early Career Investigator Award winner. He joins us to discuss his research on using existing abdominal and pelvic CT scans to help detect axSpA earlier in people living with inflammatory bowel disease. His work explores how advanced imaging analysis and AI could identify early signs of inflammation in the SI joints or sacroiliac joints, allowing faster diagnosis, timely treatment, and better long-term outcomes. In our conversation, Dr. Mayer shares how this innovative approach could bridge the gap between gastroenterology, rheumatology, and helping patients receive care sooner and reduce years and years of undiagnosed pain. I'm going to tell you a little bit more about Dr. Mayer. Not only is he an adult and pediatric rheumatologist at the Hackensack University Medical Center, an assistant member of the Center for Discovery and Innovation at Hackensack Meridian Health, and assistant professor of medicine and pediatrics at Hackensack Meridian School of Medicine. He completed his fellowship training at the University of Pennsylvania and Children's Hospital of Philadelphia, and earned a Master's of Science in Clinical Epidemiology from the University of Pennsylvania in 2025. He is a clinical epidemiologist, and his research focuses, again, on early detection and optimal treatment of axSpA, particularly in patients with IBD. He has authored multiple peer-reviewed publications, presented at international conferences, the recipient of several national research awards, and once again, a proud Jane Bruckel Early Career Investigator Award this year. He's also a Rheumatology Research Foundation Scientist, Development Award winner, and holds leadership and investigator roles with CARA, Spartan, NERDS, and PARC. You have quite a resume for a young man. Welcome.
Thank you. Yeah, unfortunately, not that young anymore, but thank you. I'm excited to.
Well, you're holding up well. So it's so nice to see you again. In the green room, we were chatting. We got to meet when you received the Jane Bruckel Early Career Investigator Award at ACR last fall. And so congratulations. It's always fun from the board side to watch people through their careers. I've found particular joy in it. So can you tell us a little bit about what inspired your focus on early detection of axSpA?
Sure. So first, I want to thank you and the entire SAA for the honor and privilege of receiving this award. This award is going to go a long way for building the research program that we're developing at Hackensack University Medical Center for addressing the streamline of care and optimal treatment of patients who have both IBD and axial spondyloarthritis. So thank you. It's going to go a long way. In terms of what got me interested in earlier detection of axial spondyloarthritis, I think that really the formative experience was in my internal medicine pediatrics residency at Penn. I had the opportunity to do a global health elective on the White Mountain Apache Tribe reservation in Northeast Arizona. And interestingly, indigenous peoples in North America actually have the highest burden of rheumatic disease out of any population on the planet. There are three distinct genetic lineages, and in two of them, there's a concentration of risk for developing spondyloarthritis, different forms of spondyloarthritis. And so when I was on the reservation doing clinical care, both for adults and children, I saw many cases of severe and early onset axial spondyloarthritis, including multiple 20-year-old patients who were wheelchair bound because their spines were already fused in various configurations. And so, of course, and this is an extreme example, there's a lot of need in terms of healthcare access in that patient population as well, but really highlighted the risk of what potential outcomes can look like if we don't identify axSpA early, whether in children or in young adults. And so that was really a formative experience. And then from the research side, that really launched my beginning to work with Dr. Pamela Weiss, who has been a longstanding research mentor of mine, and she's an international expert in juvenile spondyloarthritis, and recently published the first pediatric classification criteria for axial spondyloarthritis. And so she's guided me through this process in terms of developing my scholarly passion for axial spondyloarthritis research, really across age groups.
Yeah, that Pam Weiss is a godsend. I
Yeah.
mean, she is just incredible human. So
Yeah.
uh, I'm excited about that. And you are one of the few rheumatologists, I think, out there that treats both adults and on the pediatric side. Does that shape your perspective when you study a disease like axSpA?
Yeah, it definitely does. So yes, we're a rare breed, but thankfully there are more and more of us. So within spondyloarthritis field, not many, but within the broader rheumatology field, every year at ACR we have a meeting, and every year it gets slightly larger. And so I think this year we had something like 30 participants, and so slowly growing, many trainees, which is exciting. And so
That's
the
great.
future for combined adult pediatric care is bright in rheumatology. I do think specifically related to spondyloarthritis that it does change my perspective. There are distinct manifestations and distinct challenges in the care of children versus adults with axial spondyloarthritis. And so, for example, in children, the clinical presentation can be a lot more subtle and challenging than in adults. As you can imagine, if you're talking to a 9-year-old about symptoms and trying to elicit, do they have inflammatory back pain or where is their pain? That can be a lot more challenging in terms of really getting down to the symptoms and having a patient clearly explain where their symptoms are and give details compared to if you're speaking with an adult. And there's actually in children, there's a subset of patients who have asymptomatic sacroiliitis. And so we know from some of Dr. Weiss's studies that a proportion of patients will be found to have sacroiliitis on imaging, but not report any clinical symptoms related to their axial disease. And so it's a unique population. There are different ways we interpret the MRI imaging compared to adults as well, taking into account their normal pubertal maturational changes that happen in the sacroiliac joint. And then I think otherwise also in pediatrics, there is a lack of FDA-approved medications, which is a big barrier in the field of axial spondyloarthritis. To date, there's only one FDA-approved therapy for enthesitis-related arthritis, which generally under which axial spondyloarthritis falls. But otherwise, we oftentimes need to extrapolate and try to get an FDA indication for polyarticular JIA if they have 5 or more joints involved, sometimes psoriasis or IBD. But it's definitely lacking compared to adult axial spondyloarthritis in getting patients access to care. And so when I'm taking care of my adult patients, I think an appreciation for relatively how much easier it is to get drugs approved, not always, but compared to children. And then, there are other things that I learned in children that influence how I approach adults in terms of trying to have a better understanding of the fact that this is a lifelong disease. Oftentimes, right, we know it generally is starting in patients younger than 45 years of age, but oftentimes in the teenage years. And so being more sensitive to the impact on social and peer relationships, education, career, other outcomes that we think about oftentimes in pediatrics that I then can also address with my adult patients. And so there's definitely some distinctions, but also a lot of synergy.
Yeah, that's pretty amazing too. And I have to say, I think when we're diagnosed later in life, the career and social is often, I think, overlooked. and it's massive. It's a massive puzzle to unpack for many of us. So I appreciate that you're kind of thinking of it through the lens of we're very attuned to it, I think, when we're thinking of young people, but then as we get older, it's a little bit of self-management, I think, when you get into the system. And I know every rheumatologist differs, but that's interesting that you're thinking along those lines. Um, okay, so let's talk about IBD.
Sure.
Many people with irritable bowel disease experience back pain, but might not realize it's inflammatory. What are some signs that you can share that might be linked to spondyloarthritis?
Sure. So, as we know, back pain is very common in the United States population. Right? So, studies have shown that about 20% of the adult United States population suffers from chronic back pain. Amongst those, only about 5% will have inflammatory back pain. So, those are some questions and features that we really do try to hone in on to determine whether or not the back pain could be from a disease like axial spondyloarthritis or a related inflammatory disease. So those are features such as prolonged morning stiffness, improvement with activity but worsening with rest, waking up in the second half of the night with pain or stiffness in the lower back, alternating buttock pain, good response to NSAIDs, et cetera. And so some of those features could point towards an increased risk for having axial spondyloarthritis. However, in general, the statistics I quoted, and then in the U.S. population, only about 1%. I mentioned 20% chronic back pain, only 1% actually have axial spondyloarthritis. But amongst patients with inflammatory bowel disease, the risk is much enriched. And so, amongst patients with true inflammatory bowel disease, about 5 to 10% of patients have axial spondyloarthritis. So, and sacroiliitis on imaging is actually a little bit higher, sometimes closer to 15 to 20%. And so it's an enriched population. And so in general, what I would say is that a patient with inflammatory bowel disease who has ongoing chronic or new back pain without another clear explanation is generally reasonable to be evaluated by a rheumatologist. The Spondyloarthritis Research and Treatment Network, or Spartan, did develop draft recommendations for referral. And amongst those, you have to meet 3 points to meet referral criteria. 1 point is having IBD. And then you get additional points for elevated inflammatory markers, et cetera. But if you can imagine a patient who has active inflammatory bowel disease, their inflammatory markers are going to be elevated. They have a diagnosis of IBD and then inflammatory back pain. They would already meet criteria for referral based on those draft recommendations. There's issues with confounding from intestinal disease, but either way to say that our antennae should be up in terms of a higher suspicion for possible axSpA in patients who have IBD, just given the larger overlap with axSpA compared to the general US population.
Yeah, that's a lot.
It's a lot.
Yeah.
And when you think about, 2.5 to 3 million Americans have a diagnosis of inflammatory bowel disease. If we take 10% of those have axial spondyloarthritis, then we're talking about 250 to 300,000 patients. And so it's a large burden of disease. And then also acknowledging that this is excluding peripheral spondyloarthritis, which is actually even more common in patients with IBD. And so more recent studies, such as prospective cohort studies out of Denmark, have shown that peripheral spondyloarthritis symptoms may be as common as 40 to 50% of patients with IBD. And so there's a
Wow.
huge unmet need.
And is
from a
there a gender split on that? Do you know?
So some studies have shown that there may be greater peripheral arthritis, or at least arthritis symptoms in females, whereas males may have more axial disease. But to date, thankfully, over the past year or two, there have been better, higher quality prospective studies, but we do need more multi-center validation of some of those findings. So
Yeah.
those are just some of the historical accepted data. But hopefully we'll have more robust data in the years to come.
Awesome. So part of your research is studying how abdominal and pelvic CT scans, which many IBD patients already get, but you're studying how this could help spot early signs of axSpA? How does that work?
Sure. So, patients with inflammatory bowel disease frequently get CT or computed tomography scans of the abdomen and pelvis as part of their care for their IBD, right? So, for example, a patient with established Crohn's disease or ulcerative colitis presents to the emergency department with abdominal pain, or diarrhea, let's say symptoms of an IBD flare or maybe an infection, who knows? Generally, the first step that happens in the ER, for better or worse, is going to be a CT scan of their abdomen and pelvis. And so patients with inflammatory bowel disease are already commonly getting these scans. Now, incidentally, CT scan is actually the gold standard for evaluating half of the forms of sacroiliitis. So, right, so sacroiliitis, generally we think about inflammatory sacroiliitis that's best evaluated on MRI, at least currently, and then structural sacroiliitis. And structural meaning there are changes in the bone. We're not necessarily seeing inflammation, but is there an erosion? Is there ankylosis, where right ankylosing spondylitis gets its name, where you have bridging between the bones? Is there sclerosis? And CT is actually the gold standard and the best way to evaluate, at least for structural sacroiliitis. And so the idea is that patients are already getting these scans, and we can use those scans to identify features that are suggestive of possible underlying axSpA in this enriched risk patient population.
Wow.
And ultimately, not to say, well, we see this, can we automatically offer a diagnosis? I mean, sometimes, but generally more so as a mechanism for expedited rheumatology referral. So you can get an expert evaluation, a formal diagnosis, and started on the appropriate treatment earlier. And where this particularly becomes relevant, just to share some data, there was a really good 2018 study by Chan et al. From a group in Toronto, where they looked at patients who had CT evidence of sacroiliitis amongst patients with inflammatory bowel disease. And what they found was in the radiologist's interpretation of the CT scan, sacroiliitis was only called in the assessment in 33% of cases, and only 5% of cases were referred to a rheumatologist. So to say that we can fairly accurately detect sacroiliitis using this modality, but because the reason for getting the scan in the first place is
Isn't
abdominal pain or diarrhea, that may not be the focus, right? Either of the radiologist or the ER physician or the gastroenterologist. And so a lot of this is to, almost in a Swiss cheese kind of way, if these findings are falling through the holes,
right?
automate some of the detection, but also even beyond this automation aspect is to raise awareness of the fact that we can capture a lot of these patients and potentially offer earlier diagnosis
Yeah,
by using scans that we're already getting for other reasons.
yeah. I mean, a couple of things come to mind. So let me can I reiterate what you said about the numbers? So
Sure.
when there are a lot of people get CT scans, of the CT scans that showed
Sacroiliitis. Yep.
sacroiliitis. I don't know what's wrong with my tongue today. Only 33% of those noted it in the radiology report, and only 5% were referred.
Correct. So
Wow.
more made some comment on musculoskeletal changes, but in terms of actually saying there's evidence of sacroiliitis, it was only a third. And then only 5% of the patients with sacroiliitis identified on CT scan were referred to rheumatology. And so to say that, right, 95% of these patients were not referred to a rheumatologist, and thus it was an easy missed opportunity for evaluation. And if I may just offer an anecdotal story, and some of which like drove the passion for this idea and this project. So actually in clinic, shortly after joining Hackensack University Medical Center, I saw a 32-year-old patient who actually didn't have IBD, but it's a sort of analogous situation, who was experiencing chronic inflammatory back pain for over 10 years. Unfortunately, by the time I was seeing him, his most recent imaging showed multi-level ankylosis, so multi-level bridging, both in the lower spine as well in the neck, to the point that he had difficulty rotating his neck and difficulty driving. And those are things, right, once it happens, it's very challenging to near impossible to reverse. And so he's really functionally limited. What the analogous point is, though, to this research is I was looking back through his scans with this idea of seeing if he had any prior CT scans of the abdomen and pelvis. And he actually was seen in the ER in 2016, so about 10 years ago, shortly after his back pain started. And he had a CT of the abdomen and pelvis because he presented with diarrhea from food poisoning. And on that CT abdomen and pelvis, he has multifocal erosions in the sacroiliac joint in multiple planes in both sacroiliac joints bilaterally, suggestive that already with the back pain symptoms he was having at that point for about 6 to 12 months, that there was already destructive bony disease ongoing. However, he didn't have any bony bridging at that point. And so this is a perfect example, right? Again, he didn't have IBD, but it's a corollary example where if that was identified and he was referred to a rheumatologist, we gave him a diagnosis, started him on the appropriate therapy, it's possible we could have prevented some of this long-term irreversible morbidity. So it's an unfortunate story, but I think illustrative of what the potential here is.
But I think and I was particularly interested in this, and I'll share about a little bit about mine, was uh, from the late 90s to 2013 when I was diagnosed. I was seeing a gastroenterologist for more an IBS, never diagnosed with IBD, but kept complaining of the same symptoms. And I was having back issues at the same time, on and off. And uh, since I've been diagnosed and on the right biologic, I don't experience those problems anymore. And I saw him more recently, and he's a good guy, and I like don't hold a grudge. But he said, I haven't seen you in like a decade. I said, I know, because you know what? I finally got diagnosed with ankylosing spondylitis, and I haven't needed to come and see you. And he looked at me and he just said, I missed it. And I think there's more awareness coming in that area, which is really a relief because, and I know is it Jurgerman and Michael Weissman have done some research in this area too. This crossover is it's so stark that we have to really take the leverage, because it is sad to hear that we're looking at people's scans and we're overlooking these things when they're probably somewhat obvious, but we're just, nope, there's no IBD. Let's keep going. I mean, that has real impact for people's outcomes. I hear. I mean,
Yeah, exactly. Like whether your example or the example of the patient that I shared, for sure. And I think, I mean, understandably, right? I mean, this is not a finger pointing blame game exercise,
no,
right? I mean,
it's
people, radiologists are seeing hundreds of scans a day. And, you know, when we order these scans, for example, in the ER or other places, we put in the indication for the scan, right? So let's say a patient with IBD comes to the ER with abdominal pain, diarrhea, gets a CT abdomen pelvis. In the order to sort of then orient the radiologist, generally someone would say history of IBD, presenting with abdominal pain and diarrhea, concern for possible IBD flare versus infection. And so that's where they're really focused, right? And the
mhm.
main job is, and that's where, right, some of this more automated technology comes in, to help, not to say to replace the radiologist per se, even though I know that's sort of a broader discussion and concern in the field, but more so that it can help close those holes in that Swiss cheese model that we discussed to make sure that
Yeah.
some of these other ancillary findings aren't missed, especially when it's not necessarily the focus of the ordering or reviewing clinician.
Yeah.
Um,
I think it's, and you had mentioned, right, it's just in general, this topic is an unmet need. And I know this was one of the key areas that was brought up at the unmet needs conference, and was it 23 or 24 that SAA put on, is how do we, leverage AI and imaging and really understanding. I'm sure no patient who gets a CT for IBD wants to get a phone call from the network they're in that says, we suspect you have uh, spondylitis. But at the same time, like, many of us know, and you guys in the medical community all know, the faster you get somebody treated, the less likely they're going to have these problems. So super critical. And I imagine how much more we have. And again, it's not, I don't think it's a blame game either. I think medicine is an evolving, I know it falls under the sciences, but often I think it's art, especially rheumatology.
Yeah.
In terms of, you talked a little bit about the patterns of changes you're looking for on the scans that could impact uh, or suggest inflammation. How much more do you think there is to go in utilizing AI to really drive the connection between these two diseases?
Yeah, so I mean, I think we still have a while to go. So I mean, what we're looking to use, and again, this is like early phase, trying to develop even just a pilot algorithm as a start. But imaging recognition software has existed for decades. But now that, more around the conversation of AI and achieving better, higher powered models for better discrimination. But it's still challenging to do. Um, we are fortunate that at our institution we have a partnership with Google, and so that's one avenue by which we can potentially access and work with trained AI engineers or use technology, et cetera, to accomplish some of these AI goals that we have. But even some more basic, there are coordinate systems that can be built, et cetera, to differentiate, looking at the normal contour of the sacroiliac joint. Is there an erosion, like a break of the cortical bone that's a certain number of centimeters? And there are these validated scores that we would employ that have been published in 2016 for a certain number of erosions, or ankylosis, that you can see on CT. But it's challenging. I mean, in order to build a adequate AI model for broader dissemination and use, and generally you need multiple thousands of scans across the spectrum, from normal CT scans, acknowledging that the anatomy is slightly different in men and women of the sacroiliac joints. There are also sacroiliac joints anatomic variants that you need to consider. There's some mimics of sacroiliitis that need to be considered. Fortunately, because of the research question, it's not saying we're giving someone a diagnosis based on this algorithm. It's more to say flag someone for potential
Sure.
rheumatology referrals that the rheumatologist can figure it out, but at least get them linked in for care. But thankfully, there have been a lot of advances, but we still do have further to go in terms of actually adequately building a model that can adequately discriminate, and is well trained enough to make sure that we're also not getting a high number of false positives or false negatives. And so there's a lot of excitement around AI. We're
Yeah.
excited about this project, but still more work to be done.
Yeah, and I think you probably there's a lot of model training and machine learning that
Yep,
probably needs to take place.
exactly.
That could be a whole different episode.
Yep.
Uh, So in terms of the referrals today, what challenges, even in the work you're doing, do you see that patients have in getting referred to rheumatology when they have IBD and you want to get them taken in for rheumatology referral?
Sure. So I think there are multiple levels of issues in terms of access. So the first is availability of a rheumatologist. As many patients listening to this podcast are aware, when you're trying to get in with a rheumatologist, oftentimes because there's such a great need and a lot of rheumatologists are retiring, there's a large sort of a wave of older rheumatologists that are exiting the field, that there is a big workforce shortage really across the board. It's more pronounced in pediatric rheumatology, but the wait times to get in with a new rheumatologist oftentimes can be in the 6 to 12 month range. And so access is one issue, but there's also geographic access. For example, at my institution, it's a relatively newer, at least adult rheumatology department. And so there wasn't even an adult rheumatology department prior to 3 to 4 years ago there. And so there was a big void in the North Jersey area in terms of having to travel more down to Central Jersey, or maybe some overwhelmed private practices, or going into across the bridge with the traffic into New York City. So some of it's access, more in sort of rural, Midwest, mountainous US. Then we're also talking about larger distances to get to a rheumatologist. And particularly in pediatric rheumatology, I think there was a report from a couple of years ago that the average distance for a pediatric patient to see a pediatric rheumatology in the United States was something like 60 to 70 miles. So geographic access, workforce shortage, I mean, that's a big part of it. More pertinent to my research, also a lot of it is recognition of disease. So for example, in patients with inflammatory bowel disease, to be specific to the population that I study, I think there's a couple of barriers. So the first is usually that the physicians who would be referring to us generally are the gastroenterologist. And so I think comfort amongst gastroenterologists in differentiating types of musculoskeletal pain, inflammatory, non-inflammatory, understanding what's maybe higher risk inflammatory back pain or other features that should prompt referral to a rheumatologist, and then just general recognition of possible disease. I think there's also confounding from if a patient has abdominal pain, is it the pain radiating? If they're having a low back pain, is that some radiating pain from their active intestinal disease? Is it really arthritis, et cetera? And then also, I think the final thing I'll mention about that is historically, I think there's been this dogma that, and why IBD spondyloarthritis specifically has been understudied, is there's this dogma that, why do we really care? Because you treat the intestinal disease and the arthritis goes away. But we know that that's not true, particularly for axSpA. Sometimes in peripheral disease, it can, but not always. But then also now that we have so many more advanced DMARD therapies, biologic therapies, targeted synthetic DMARD therapies, a lot of therapies that are used to treat IBD are not created equal when you're talking about spondyloarthritis. And so, for example, for axial spondyloarthritis, there's actually only two classes of drugs that will treat both IBD and axial spondyloarthritis. Generally we think of TNF inhibitors, IL-17 inhibitors, and JAK inhibitors, and maybe NSAIDs is first line. NSAIDs, maybe we'll talk about it in a little bit later, but is a different focus of my research. But generally, the American guidelines at least have said that NSAIDs should be avoided where possible in patients with IBD because of concern for flare, although some of our data and other emerging data have started to push back a little bit against that. And then IL-17 inhibitors, there are concerns that it can either cause de novo IBD or lead to flares of existing IBD. And so generally those are contraindicated in patients with IBD. And so if you have axial spondyloarthritis and IBD, your only options really are TNF inhibitors or JAK inhibitors. And so recognizing both diseases early so you can start on the appropriate therapy is really critical. So not to belabor too much, but I think that there are multiple levels of what the issues may be. And so we have our work cut out for us, but I think addressing one at a time and starting to slowly move the needle and working really in tandem with gastroenterologists to move the needle together is paramount.
Yeah, and and this is thinking about like the importance of early diagnosis with either adult or pediatric patients with IBD or the general population. I mean, we know our IBD patients with axSpA roughly the same, like on that 7 to 10 year average diagnosis point, like.
So generally, I think in the studies of axSpA where patients with comorbid IBD have been included, then I think generally, yes, like things get lumped together in that 6 to 7 to 10 year diagnosis delay. But to my knowledge, there hasn't been a specific prospective study that's looked at this IBD axSpA population individually. But generally, the thought is that it's sort of along that similar timeline. But for the reasons that I mentioned, you could hypothesize that if there are other confounding factors, et cetera, then it's possible that the diagnostic delay could even be longer. We just don't have robust data to specifically say that at this point.
Yeah, it's really unfortunate. I call the diagnosis delay the lost decade. And I think what shows up during that time is a lot of what you talked about, thinking about how people live their lives and professional and social opportunities. That has that like massive impact that even after diagnosis can take a lot of time to bounce back from, aside from the physical issues.
Sure.
So
Yeah,
thanks for
I
that.
like that. I like that term of the lost decade. I think that's very appropriate. And of course, right, there is the lost decade in terms of chronic pain and suffering that was potentially preventable, but then also, as we said, impact on peer relationships, functioning within family and career, et cetera. But then, unfortunately, amongst the sizable minority of patients who develop irreversible damage, right, over that time period, such as the patient who I mentioned, the 32-year-old patient with 10 years of chronic back pain and clear progression and fusion of the spine and neck over the course of that 10 years is something that unfortunately we can't fully reverse.
Right. Okay, so let's move to NSAIDs because
Sure.
you've studied medication safety. Uh, what should patients know about that connection for IBD and spondyloarthritis?
Sure. So this is a passion of mine, so I appreciate you bringing it up. So NSAIDs, it's a very controversial topic within the field of IBD and related spondyloarthritis. So we know that NSAIDs are first-line guideline recommended therapy for various manifestations of spondyloarthritis that overlap with IBD. So for sure, right, axial spondyloarthritis, we know first-line therapy in the most recent axSpA guidelines from 2019. But then also first-line therapy for non-inflammatory musculoskeletal pain, things like enthesitis, dactylitis, peripheral arthritis, et cetera. However, based on historical studies in IBD, some of which have been problematic, and recent studies have highlighted the problems with a lot of those historical studies, there's been a concern that use of NSAIDs in patients with IBD may trigger intestinal disease flares. Recently, there was a really high impact paper from 2023 from Shirley Cohen-Meckelberger's group at the University of Michigan. It was a great epidemiology paper where essentially they showed that there's a concern that a lot of the historical studies that have attributed risk to NSAIDs may have been from what we call reverse causality, meaning that, right, if you look retrospectively, so if you look backwards and say, well, this patient had an IBD flare and they were using NSAIDs, and so maybe the NSAIDs trigger the IBD flare. But the timing is really important, right? So this study essentially raised the question of, well, are we just measuring it wrong? So for example, plausibly, was the patient potentially having an IBD flare already, and then they're using an NSAID because they're having a lot of abdominal pain or joint pain associated, and then we're sort of falsely attributing the flare to the NSAIDs that they started only after the flare had started, for example. And so there's a lot of problems with the historical data. And when we look at the only meta-analysis to date, right? So the meta-analysis is sort of aggregating all the studies to date that have looked at NSAID risk in IBD. When they pool the studies, they actually haven't found a significant increased risk of IBD flare. Within that meta-analysis, when they look specifically at studies that had the highest rigor and the least chance of bias, what they found was that there actually seems to be more nuance, right? So currently, the American College of Gastroenterology guidelines, for example, just says across the board, don't use NSAIDs. But what we found in the literature and what our studies have supported is that there probably is more granularity by IBD subtype as well as by NSAID subtype. So if you look through the literature, there is more conflicting data in terms of the risk of IBD flare amongst patients with Crohn's disease. And in our study, which we presented this year at Spartan at ACR, and hopefully will be published in the next month or two, we similarly found that there seems to be a relatively elevated risk of IBD flare in patients with Crohn's disease. However, in patients with ulcerative colitis, in our large retrospective cohort study, it was 270,000 patients with IBD. We did not find a signal for an increased risk of IBD flare associated with NSAID use. And even to the point when you look at the European IBD guidelines, they specifically acknowledge the fact that there has never consistently been a risk found in patients with ulcerative colitis attributed to NSAID use. So beyond IBD subtype, that's one thing. And there are many other studies I can comment on, but that's sort of broad overview. The other piece is that not all NSAIDs are created equal, right? So there are the NSAIDs that all of us love and use for various aches and pains like ibuprofen and naproxen, things that we call non-selective NSAIDs. Those inhibit two enzymes called COX-1 and COX-2 that can have, as we all know, can upset your stomach if you don't take it with food. And there's more concern about potentially causing intestinal disease flares in inflammatory bowel disease. There are other types of NSAIDs called COX-2 selective NSAIDs. So if you've heard of celecoxib or Celebrex, for example, that target only one of those two enzymes and so have fewer gastroenterologic side effects. And there's been more consistently data to suggest that the risk is probably lower of IBD flares, to the point that there were actually two randomized control trials of COX-2 selective inhibitors in patients with IBD, neither of which found a significant increased risk of IBD flare. And so in my practice generally, even though the current guidelines say don't necessarily use NSAIDs in anyone, with some discrepancy in the European guidelines, working together with a gastroenterologist, if we have a patient whose intestinal disease is in remission, they're on stable therapy, and particularly patients with ulcerative colitis, if they have a need for an NSAID, usually we'll give them a couple of weeks course maybe of a COX-2 selective NSAID. And anecdotally, we haven't really seen many adverse outcomes. And clearly we know there's benefit, right? These patients are having pain and there aren't good alternatives, right? We're going to give them
Right.
steroids or opiates or less effective analgesic therapies. And so a little bit long-winded, but it's an important study and an important point, because I think there's a lot of unmet need in the IBD population amongst patients with musculoskeletal disease who have a need for NSAID use. And so we need more study, but at least moving the needle to at least start raising question marks rather than saying it's totally black and white.
Yeah. Well, I think that's a lot of this sort of
Yeah,
disease.
a lot. That's right. Right. I guess that's the theme overall, but even more so in the topic of NSAID use in IBD. But
Yeah, no, that's really interesting. Well, and the COX-2s, weren't they designed specifically to like be a little less harsh on the stomach?
correct. Yeah. So, and then, there was we published a paper in Arthritis Care and Research early in 2025 that it showed that's right. There was a lot of uptake when they were first came out, but then in 2004, when the data came out, there was concern for heart attacks and other adverse cardiovascular outcomes. And a couple of COX-2 selective inhibitors were removed from the market. That the use of those agents in patients with IBD precipitously dropped and have been sustained low over the past 20 or so years. And so I think there's a lot of still stigma. There was actually some recent data that shows that the cardiovascular risk may not be as high as we used to think it was, from a New England Journal paper, I think from 2019. But either way, to say that there's probably still more room for greater use if in the right patient population.
Yeah, that's fascinating. And does, if I can just go off on a slight tangent, does like what do they call them? Proton pump inhibitor,
Mm-hmm.
will those assist where there may be some issues and sensitivity to the NSAID?
They can, and particularly, there's actually formal guidelines about this. I believe 2008 American Gastroenterological Association, in association with a few other organizations, released guidelines for the use of NSAIDs, particularly in elderly patients. And they have a specific flow algorithm for using proton pump inhibitors or PPIs in patients using NSAIDs, including if they're also on chronic steroids, if they're taking a blood thinner or aspirin, and in patients over a certain age. And so there's an algorithm in terms of like certain risk factors, et cetera. But if there's any degree of side effects, then it's something that's reasonable to try to see if it could help
Yeah.
mitigate symptoms.
Okay. Okay, so let's think off into the BHAG sphere. Uh,
Sure.
if you had one thing you could envision in the future for how gastros and rheumatologists collaborate, what would that be?
Yeah. So I don't know if this is a cheesy answer, but in some ways, that the future is already here. So yes, we acknowledge that we're behind other forms of spondyloarthritis, like axial spondyloarthritis, like pure axial spondyloarthritis or psoriatic arthritis, but which is exciting in terms of the opportunity. But there are already internationally a handful of groups that are working jointly, no pun intended, rheumatologists and gastroenterologists together, including a group that I'm a part of, where we're looking to prospectively study, better characterize disease, and work really hand in hand, meeting each other halfway to really better understand the interplay of these two diseases, pathophysiology, disease manifestation, treatment outcomes. And so a lot of that's actually already been forming over the past 3 to 5 years or so. And in terms of what we're doing locally, which is sort of an exciting new update, is I have a fantastic collaborator at the Hackensack University Medical Center, Dr. Alyssa Perrian, who's our director of the Adult IBD Center, who just joined us from Hopkins in the past year. And we're actually starting a formal combined IBD spondyloarthritis clinic, where once a month she and I will be seeing patients with either established both diseases or one established disease and suspicion for another together as a gastroenterologist and rheumatologist, where we sort of stagger seeing patients, and then we come together, discuss a joint assessment and plan, and then present that to the patient together. And really to streamline their care. I mean, it is going to be a backbone also for some of our prospective research data collection. But then also, getting patients biologic therapies approved more easily, and trying to really expedite and streamline the clinical care with the hope, right, of course, of improving long-term outcomes in these patients. And so trying, again, in our own center to slightly move the needle, but there are now multi-center collaborative efforts to try to push things forward more broadly. And so I anticipate, I give other people the analogy, almost it feels like this is where, for example, like psoriatic arthritis was maybe 10 to 15 years ago, right? And now you can't watch TV without seeing a psoriasis or psoriatic arthritis drug commercial.
Right.
But it sort of feels like we are on the precipice of pushing things forward in that similar model. And things may look very different in another 5 to 10 years from now in terms of collaboration, understanding of disease, and availability of therapies for this specific indication.
That's super cool. There's been so much. I mean, I know we're far, far, far away from completely knocking out the diseases, but just even the last 20 years, all that has happened, it's so rapid. And I feel a bit, and maybe you have a better sense of this, but I feel a bit that there was a lot of this collaborating going on during COVID. And it's just kind of blossomed now and it's taking legs, which is super cool. Uh, okay, so last question. What message of hope would you share with patients who have IBD and chronic back pain but don't yet have a diagnosis?
So I think in general, the message I would make is that you're not alone. So as per the data I presented, back pain and specifically axial spondyloarthritis is very common amongst patients with inflammatory bowel disease. So this is not just a you thing. And hopefully it's not axial spondyloarthritis, but if it is, I think the important thing is advocating for yourself. Hopefully, if you're listening to this podcast, maybe this can be a trigger to sort of empower you to bring up those symptoms more prominently, whether with your primary care physician or your gastroenterologist. And again, they may not be able to get you to a formal diagnosis, but really the big hurdle is recognizing the symptoms and if they're concerning enough to then get you a referral to rheumatology. And again, right, in patients with IBD where there's already an enriched risk for axial spondyloarthritis, I think the threshold for rheumatology referral should be low. And so hopefully using some of these data, again, to advocate for yourself, have other people advocate for you, other healthcare providers for this drastically under-recognized disease, and understand, right, that it can really have big impacts in terms of long-term outcomes for the musculoskeletal domain. But then also, if we treat both the musculoskeletal and gastroenterologic domains jointly, there could be a synergistic effect. And ultimately finding a therapy, like as you were saying, Jill, in your own experience, starting on something that can really impact your symptoms and outcomes in the long term across multiple domains. So more work to be done for sure, but hopefully at least the information provided today will inspire some patients to advocate for themselves more prominently in terms of the symptoms that they're experiencing.
Yeah, and I think, as we're talking today, not the day that this airs, but today, right? Our government is voting on federal funding for medical research, which technically ends tomorrow if we don't get this through.
Yeah.
And I don't know that everybody realizes. I know there's a lot of other things going on in the air, but it makes what we just talked about and the opportunities there and the people that suffer, it makes it so much more important to make research dollars available. And I don't know if listeners realize that axSpA, spondyloarthritis, and IBD are highly underfunded to begin with. So we need more on the federal funding side. But we had a conversation, I think it was at ACR, I think maybe it was Jim Rosenbaum who said, I think that SAA is the biggest funder of axSpA research right now in the United States, given all that's gone on. And it's so critical that we don't like lose that momentum. And
Yep.
I don't know that you need to, you can comment as you wish, but I'm feeling very like emotional around what the long-term impacts for people with our diseases may experience, or the people that won't be diagnosed because of our inability to fund some of this work. It's really tough.
Yeah. Yeah. No, I mean, I think it's frankly, it's scary, right? I mean, I think there are implications for research across the board, a lot of
Yeah.
promising work that's coming out, which may need to be shut down or curtailed if funding dries up. I mean, for me, I, of course, have a biased perspective, but for me as an early career investigator, the funds are really critical, right? At a stage where you're transitioning out of your training, trying to establish yourself as an independent investigator. The government awarded grants, like from the NIH. So, for example, like the K23 or K08 mechanisms, those are generally seen as the benchmark and the big threshold to achieve in terms of actually building, establishing, and sustaining your program to launch you into that independent investigation career. And so we know that fewer people are going into academics and into research, whether it be for financial reasons or because of the funding cuts or lifestyle or other things. And if those changes are made, then it would disincentivize more people to go into research, but then B, amongst early career investigators who are trying to gain a foothold and become that sort of next generation of prominent researchers who are making an impact in the field. Many of them may ultimately not make it or have to
Yeah.
pivot away from research if the funding dries up. And just to, this is not a like, I was not told, this is not a plant or like a told to put this plug, but this is where, right, like the award, again, I feel very privileged to have received from the SAA, my award from the Rheumatology Research Foundation, non-governmental foundations that can help support young investigators to do work that leads them to the next step in their career while there's a lot of federal uncertainty
Yeah.
are more important than ever. And so very appreciative in the fact that we're able to, this combined clinic that we're building and using that as the cornerstone for our research enterprise. A lot of this wouldn't be possible without the funding of
Yeah.
funders like the SAA.
And
So really are very appreciative.
yeah, and I always think of like sort of the next bounce of that ball is if we can't launch early career investigators to do the research, which generally becomes in many ways translational and commercialized into products or solutions or tools or new software, it stifles the ability for those things to appear down the road in 2, 3, 5, 10, 15 years that give you the automated software that will tell you if you need to be flagged, because it starts to stifle the investment in the future of innovation in the area. So it is, I mean, I live that side of it every day in my day-to-day job, and it's a very difficult thing to look at how research is where we begin in the solutions that become commercialized. And they're so critical. So um, this could be a whole nother, this could be a
Yeah.
8 hour
No, but I
long
think it's
podcast.
a very
But
important
we'll
point, and I
we'll
appreciate
pause
you
it
raising
there.
it. Yeah.
But thank you so very much for the work you do and for joining us today. And I speak on behalf of, I think, everyone at SAA and the board that we are very excited to watch your work unfold and continue to see you flourish.
Thank you. And again, feel very honored and privileged. And so thank you again for the award, for the opportunity to discuss my work a little bit today, and hoping for a bright future and better outcomes for all of these patients.
Keep up the good work.
Thanks, Jill.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.